Hello, today we're discussing hypertrophic cardiomyopathy, also known as IHSS. Um, IHSS is a condition where you have thickening of the muscles. It is commonly diagnosed in echocardiography if you have a thickening of greater than 15 millimeters or 1.5 centimeters, um, or in people with family history more than 1.3, then you have hypertrophic cardiomyopathy in the absence of any other cause for thickening, such as hypertension. Um, Now, the root cause of this condition, it's a disease of the sarcomere, and more than 50% of the patients have a MYBPC3 myosin binding protein C or myosin heavy chain mutations. Um, a lot of these are autosomal dominant inheritance, and even though you may have the gene, does not dictate the kind of phenotype you have. You may have hypertrophic phenotype or sudden cardiac death phenotype, even though the gene may be similar. Now, the basic pathophysiology involves um, exertional dyspnea. This is because of thickening of the muscle, diastolic dysfunction, elevated LV-EDP, and pulmonary hypertension because of this. The second pathophysiological component could be syncope because of dynamic outflow obstruction with a sudden drop in cardiac output, or because of rhythm disturbances. The third mechanism could be angina, which is due to supply-demand mismatch on account of the LVH and microvascular problems. Now, you have basically obstructive hypertrophic cardiomyopathy and non-obstructive hypertrophic cardiomyopathy. In obstructive hypertrophic cardiomyopathy, there's dynamic LVOT narrowing due to systolic anterior motion of the mitral valve leaflet. There's a crescendo-decrescendo murmur that is louder with Valsalva. The increased gradient stress drives the phenotype, and the treatment is beta blockers and myosin inhibitors. For non-obstructive hypertrophic cardiomyopathy, there's diastolic dysfunction, elevation of the LV-EDP. The murmur is often absent. There may be an S4 gallop present. This is highly dependent on NT-proBNP, which rises and shows severe wall strain or congestion. And the treatment could be SGLT2 inhibitors, and treatment as for heart failure preserved ejection fraction. Now, considering systemic anterior motion of the mitral valve, here is a schematic. Basically, the septal hypertrophy increases the velocity of the blood going on the side of the mitral valve towards the septum. Due to increased velocity, there's a drop in pressure. Due to the drop in pressure, the mitral valve leaflet gets sucked anteriorly towards the interventricular septum. This worsens the obstruction, and as the leaflet is moved, there is mitral regurgitation. This whole conundrum causes symptoms, and over time, the mitral valve may get completely damaged, and the patient may need myomectomy plus mitral valve repair or replacement. Now, on echo Doppler, instead of having the profile as shown on the left, which is seen in fixed obstruction such as aortic stenosis, in dynamic obstruction hypertrophic cardiomyopathy, you get a dagger-shaped Doppler presentation. Now, clinical threshold is a gradient more than 30 millimeters mercury, which defines important obstruction. A gradient of more than 50 at rest or provoked is the indication for therapeutic intervention. Now, for diagnosis, you do a resting transthoracic echo, which may show LVH and LVOT gradient, systolic anterior motion of the mitral valve leaflets. You can do provocative measures such as Valsalva, which worsen the SAM and increase the LVOT gradient. You can do an exercise stress echo. On exercise stress echo, if symptoms persist, but the gradient is less than 50, then this is not an indication for myomectomy, etc. Cardiac MRI is indicated when you have poor echo windows or to identify the underlying variant of hypertrophic cardiomyopathy. Apical variants are better diagnosed on cardiac MRI. The myocardial fibrosis and scarring is better seen on cardiac MRI. Now, if you have volume depletion and you're not drinking enough water, the cavity size decreases, and on account of the decrease in cavity size, alveolar obstruction worsens. Further, another phenotype to consider is patients who have aortic stenosis. If you fail to identify that they also have dynamic obstruction, when you relieve the aortic stenosis with a TAVR, the underlying IHSS like pathophysiology is unmasked, and the patient become catastrophically ill because the septal hypertrophy sucks in the mitral leaflets, and the obstruction is back. Now, tissue characterization with cardiac MRI is quite important. It differentiates hypertrophic cardiomyopathy from cardiac amyloidosis, Fabry's disease, athlete's heart. The apical variant is best diagnosed on cardiac MRI because it's often missed on transthoracic echo. Fibrosis and scarring is seen in late gadolinium enhancement, and if it is involving more than 15% of the LV mass, is a critical risk modifier indicating the need for quick ICD. Now, there is also a problem with sudden cardiac death. If there is massive LVH, if there's a family history of premature sudden cardiac death, if there is unexplained arrhythmogenic syncope, if there is LV apical aneurysm formation, if LVEF is less than 50%, or if there's non-sustained ventricular tachycardia on routine monitoring, these are all warnings that this person may be at risk for sudden cardiac death, and the ICD should be considered quickly. Now, first foundational problem to address is the alveolar obstruction, and you address this by using non-vasodilating beta blockers, calcium channel blockers such as verapamil or diltiazem. Second is targeted pharmacotherapy with myosin inhibitors like Mavacamtan, also known as Camzyos, or disopyramide. Third is septal reduction, which is surgical myomectomy, alcohol septal ablation. And fourth step, if people go into cardiomyopathy, burnt out IHSS, then LVAD, heart transplant, etc. would be needed. Now, the goal is to decrease the heart rate, because if you decrease the heart rate, you improve the filling. The first line treatment is with non-vasodilating beta blockers such as metoprolol. It slows the heart rate down to increase the diastolic filling. An alternative, as we discussed, is verapamil or diltiazem. Avoid vasodilators, as this could cause a significant problem. Now, at the molecular level, newer medications have been found, such as Camzyos, also known as Mavacamtan, and these specifically target the underlying sarcomere, reducing the number of active actin-myosin cross bridges and lowering the hypercontractility. So, they were tested in clinical trials where they were taken, where patients were going to undergo myomectomy, actually surgery, were randomized to these medications versus surgery, and these medicines are shown to be quite effective. It is important to remember you have to keep a close eye on ejection fraction on patients on these medications. Okay, now moving on to surgical septal myomectomy. This is where you do open heart surgery, remove the part of the septum that is obstructing, and may also need repair of the mitral valve. You also concurrently address the elongated leaflets and papillary muscles that are often seen in these patients. The pacemaker risk in this is lower, around 5%. The ideal patient profile is a young patient with massive thickness. The other intervention is alcohol septal ablation. You basically inject alcohol into the artery, the septal perforator branch of the LAD. And you don't intervene on the mitral valve. In this case, there's a higher risk of AV block and pacemaker need. And this is reserved for older patients who are not good surgical candidates. Essentially, you're causing a heart attack. In burnt out hypertrophic cardiomyopathy, the hypertrophic phenotype is replaced by scarring, dilatation, and cardiomyopathy. And in this case, advanced therapies such as LVAD or heart transplant may be needed. Now, the EF has dropped to less than 50% in these patients. So, basically, we should suspect hypertrophic cardiomyopathy in patients who have LVH, who have a ejection systolic murmur that worsen the dynamic maneuvers, and echocardiography is the initial diagnostic, stress echo and cardiac MRI later. There is pills available for this, failing which people can undergo septal myomectomy and or alcohol septal ablation. Further, ICDs are needed for those with sudden cardiac death risk. Thank you for watching. More to follow.